Hi, everyone.
Hi. Oh,
Who
I'm
you are.
Lisa,
And I'm Steph. And
and
together
together we
we're
are
PD
PD
Connect.
Connect.
Thank you so much for being here. We are PD Connect. We teach, we're a nonprofit in the San Francisco Bay Area, but virtually wherever you are. And we teach exercise and education for people with Parkinson's. And you're at our speaker series. So thank you so much for being here.
Yeah,
Go
it
ahead.
is our first Monday of the month speaker series.
That's right.
And today we have the great pleasure to talk about deep brain stimulation. And I'm so excited to share with you folks. I'm going to switch so you can let people in.
Okay.
I am so excited to introduce our host, and I'm just going to read this, but let me
Oh
give
no.
you some pointers. Yeah, okay, so Pamela Rose Zeilman. Okay, Pamela Zeilman is an advanced practice registered nurse specializing in deep brain stimulation and movement disorders at the University of Florida Fixel Institute for Neurological Diseases. With nearly 2 decades of expertise in DBS programming, patient education, and multidisciplinary care, she has been instrumental in expanding UF Health's nationally recognized DBS program.
Amazing.
Pamela has trained more than 70 national and international neurology fellows and served as a mentor to nurse practitioner students and Parkinson's Foundation Nurse Practitioner Fellows. Now, this goes on and on and on, but let me give you some of the highlights. Her publications include book chapters and peer-reviewed articles on DBS troubleshooting, programming strategies, and patient-centered care. Folks, she wrote the book, okay?
She wrote the book.
If
That's
anyone
right.
is going to give you good advice, it's the person who wrote the book, and you want to listen to what she has to
Absolutely.
say. She has received honors such as the POCN 2025 Top Neurology Nurse Practitioner Award.
High five.
I'm going to stop there.
Okay.
Okay, because if you think about how many millions of nurses and nurse practitioners there are in
Yeah,
this world,
that's a big deal.
what an honor it is to welcome Pam. Thank you so much.
Thank you for being
Thank
here.
you.
All
Okay,
right, now we're gonna go away.
move the
We're
spotlight.
gonna take our spotlight away. Wait, here we
Can
go.
I?
I'm gonna add spotlight. Here we go. There we go. And remove
Okay.
ours. Here we go. All right,
All
it's
right.
you. You did
Great.
it.
All right. Let me go ahead and go to share screen. Here we go. All right. So hopefully everybody can see that, and I'm going to go ahead and start from the beginning of the slide. There we go. So thank you for that wonderful introduction. It actually almost made me want to listen to the talk too. So I'm going to be doing a talk on the basics of deep brain stimulation for Parkinson patients and frequent DBS patient questions. First, I'm just going to give a shout out to all the wonderful people that I work with here at UF Health, and also to the Center of Excellent Organizations that have honored our location with funding to help patients. And if it wasn't, it's not just, the information I'm sharing with you is information from all of the providers that work here at the University of Florida and everyone's hard work. My disclosures is that I've participated in studies funded by Medtronic, Abbott, and Boston Scientific, and I program all three devices. I also have been a consultant for all three companies as well. So hopefully that makes me not biased. I try not to be biased. I try the best that I can. Anyways, this talk is just a tip of the iceberg. Oh, I'm giving a talk to PD Connect. Okay. All right. So, anyways, this talk is just the tip of the iceberg. This is 20 years of learning for me that I'm going to be giving you in 1 hour. So, it's going to be difficult to really, talk about every little possibility and every little nugget, but these are the different areas that I'm going to speak about. And at the end of each little section, if any of you have 1 or 2 questions, just put them in the little chat, or you could type in the chat area, and then Lisa and her coworker, they can help me with the chat and just tell me what the questions are. So we're going to go ahead and first start with DBS history. So in the early 1950s, doctors began lesioning to treat certain movement disorders in certain areas of the brain. A lesioning is kind of where they burn a little area in the brain. So basically, they're inducing like a stroke in a certain area of the brain. And they found that when they did that, that could help some patients with tremor or other symptoms that they had. Well, you know, it's not such a good idea to burn a hole in a certain area of someone's brain, right? There's pros and cons with that. And so we know that the brain works through electrical signals. And so then there was some discussion, well, can we disrupt these electrical signals with electrical stimulation instead of making these lesions? So the first DBS operation for Parkinson's was performed in 1987 by Professor Benavent. He was in France, so a French neurosurgeon. And the first report published by Dr. Benavent was in 1993, showing that DBS could be safe and effective in patients with Parkinson's. And then in 2002, the use of DBS for the condition of Parkinson's was approved by the FDA. So that's just a really very quick, brief overview of the history of DBS. And what exactly is DBS? So it's a surgically implanted medical device, like a cardiac pacemaker, to deliver carefully controlled electrical stimulation to precisely targeted areas in the brain. And it works, you know, by stimulating specific structures that control movement and muscle function. So basically, you know, we don't really know exactly how it works. We just have theories, and what's really important is that we know that it can work in select patients. And to the level that it works varies from patient to patient as well. One of the jokes we used to give is that you could have two neurosurgeons and ask them, how does DBS work? And they'll give you three opinions, okay? Because we're mostly working on theory, and over the years we've learned more and more, and just when we think we know it all, we learn something else. And that's the other thing I like to say is, as soon as you think that you don't have anything else to learn, that's when you're the most dangerous, okay? We always have room to learn something new. So in terms of DBS candidates, now I said that I would stop and answer any questions, but I think it's kind of early in the talk to ask questions yet, because what you're thinking I may be talking about later on. So let's go ahead and talk about DBS candidates, because that's really important too. Who is a DBS candidate? We want a patient to be evaluated and treated by a qualified movement disorder neurologist, and that person clearly be diagnosed with idiopathic Parkinson's disease, not a Parkinsonism, like multiple systems atrophy, progressive supranuclear palsy, cousins to Parkinson's. We want that person to have idiopathic Parkinson's disease. The patients do tend to be younger, below the age of 59, but they can also be older. I mean, here at UF, our youngest DBS patient was at the age of 18, and the oldest DBS patient, I think, was 89. We did recently have someone who was 95, but I think they had essential tremor. So, you know, older age, this doesn't necessarily mean you can't have DBS surgery, but it does increase your surgical risk. So we have to look at a lot of things to decide, you know, if doing DBS surgery is a wise thing to do. You want that person to have a significant response to medication. Usually insurance companies want that person to have at least a 30% or preferably higher benefit from their Parkinson medication. That number is really arbitrary. Neurologists kind of hate that 30% number that insurance companies kind of grab onto. Because really, they just pulled that out of the hat when they started doing research for carbidopa-levodopa in the 50s and the 60s. They just said, 30% improvement is appropriate. It's not really based on any hard science, right? And if you don't have a 30% improvement, does that mean you're not a surgical candidate? No. But you have to have conditions that are not responsive to medication, but can still be responsive to DBS. So what's an example of that? So some people can have tremor, and sometimes the medication doesn't completely help their tremor. So they may have tremor that's not responsive to medication. Tremor not responsive to medication can still be responsive to DBS. And sometimes medication will cause dyskinesia, and DBS can suppress dyskinesia. So again, you don't necessarily have to 100% have a 30% response to medication, but in general, we say the benefit you get from your DBS is the benefit you can expect from your medication. The next thing, you want to have symptoms that are refractory to medication. So we already talked about tremor and dyskinesias. People may also have early wearing off or on and off fluctuations. They may have sudden off. So, basically motor fluctuations in terms of their day-to-day management of their disease with carbidopa, levodopa, or other Parkinson-type medications. You want no or little cognitive dysfunction. Many Parkinson patients will suffer from frontal and memory deficits, but are not quite, they're still functional in their daily lives. So the memory issues aren't really affecting their day-to-day life, and they could still be a surgical candidate. But if you're starting to get into issues with your memory and thinking that are impacting your activity of daily living, you may not be a good surgical candidate. Any patient who gets DBS surgery, there's a risk of impacting and worsening memory and thinking. Even someone who doesn't have Parkinson's. I mean, we're drilling a hole in your head, we're putting, something in your brain, we possibly can impact memory and thinking. So that's something that we look at. We also want the patient and family members to understand DBS expectations. If reasonable expectations are not given, then it's going to be a failure. If you're expecting DBS surgery to help with urinary retention, you're going to be upset because it doesn't do that. So you need to know what DBS can help with and what it won't help with. So setting up reasonable expectations. The other tough part is it's so much information that we're giving to people all at one time. Sometimes the information is given to them, but they either don't remember it, or then the other thing is that they really are hoping we're wrong, right? So, wrong that, it's not going to help with X, Y, Z, and then that person may say, well, maybe it still will. And then in terms of who is a DBS candidate, who decides who is a DBS candidate? And some centers, they just have a neurologist or neurosurgeon that makes that decision. There's other centers that will have a multidisciplinary team. They'll collect information about the patient, and then that team will come together and make that decision. At UF, we first have our patients see a movement disorder neurologist, again, to look at all those things we just talked about. Diagnosis, response to medication, good medication trials, all right? And then if the movement disorder neurologist believes that this is reasonable to consider DBS, then they'll refer the patient to what we call our DBS surgical evaluation. And when our patients do a DBS surgical evaluation, we have them do a 2-day evaluation, and they see multiple people in our team. Neurosurgery, psychology, psychiatry, occupational therapy, physical therapy, speech and swallow, dietitian, social work. It's a whole team of people, okay? And then what does the team decide? If it is a team, right? What are they deciding when they gather all this information together? Well, we look at risk versus benefit, and we want the benefit to outweigh the risk. The first thing we look at is that memory and thinking. Where are you on that risk, in terms of impacting memory and thinking? Are there any unacceptable comorbidities? Do you have a heart condition and maybe, your cardiologist doesn't think you should have the surgery? Now, saying that, look, we've done surgery on plenty of patients who are on blood thinners, who have had cardiac histories. The vast majority of patients, even if they've had like a heart attack and they have a stent, they're still surgical candidates. But, someone who has very advanced congestive heart failure or cardiomyopathy, they may not be a surgical candidate, okay? So we look at different health conditions, and are those health conditions too risky to do the surgery for you? And then we want the person to have symptoms that bother them that the DBS can potentially treat. If the symptoms that bother you are symptoms that the DBS is not going to help, we shouldn't do a surgery, because you're just going to be disappointed and you're not going to get out of that surgery what you want. We then decide what area of the brain are we going to place the DBS electrode in. One side of the brain treats one side of the body. So right brain treats the left side of the body, left brain treats the right side of the body. And then what area in the brain are we going to put that lead in? There's different areas, and we're going to talk about that in another section, okay? We decide, do we need to treat only one side of the brain or both sides of the brain, okay? We're going to decide how quickly we're going to do that. Are we going to put both leads on both sides of the brain in the same surgical setting? Are we going to space them out a month at a time? Or do we need to space them out even further, 6 or 7 months out of a time? If we have someone that we put in a high-risk cognitive category, but we still think they can still proceed forward with surgery, we tell that person, we have some concerns. You're in this high-risk cognitive category. We're going to be a little more conservative. We'll first treat one side of the brain, and we'll wait 6 or 7 months, program that first side, make sure you're doing okay. And if we think it's safe to move forward for the other side of the brain, then we'll do that. So that's, something that we discuss here too. Some places don't do that. They just do both sides and they don't take a conservative approach. So every center is different. And then, which DBS vendor are we going to use? So there's 3 main companies in the United States. And so, which company are we going to use? Which DBS battery are we going to use? Are we going to do a primary cell or rechargeable? Where are we going to put that battery? Are we going to put it in the chest or the abdomen? Or are we going to put it on the right side of the chest or the left side of the chest? We talk about all those things. And then is the person under any anticoagulation? Do they need any surgical clearance? Like, do we want them to first get a clearance from their cardiologist or their pulmonologist or whatever underlying medical condition that we're worried about? Are we going to make that person get clearance from that provider? And what is our radiology plan? Can we do an MRI? We would like to do an MRI. Does the person have a pacemaker? Is that pacemaker MRI compatible? We look at all those things. Okay. So now we're at the tip of the iceberg again, and we're talking about lead location. So before I move on, do we have any questions? Yes. Okay.
There is one in the chat. If you
okay.
See, or I can read it to you.
Yeah, go ahead and read it to me.
So the question is, meds make me so unbearably sick, I cannot take them. Will that disqualify me from being a candidate?
That's an excellent question. No, it will not. We just have to document clearly in the chart that you're unable to tolerate medication, right? So that's another thing we have to document clearly so that when the insurance company reviews it, they're not going to hold us to that 30% improvement. The other thing is sometimes we're not able to dose the person up to therapeutic regimen because as we go up on the dosing, then their dyskinesias are too severe. So in that case, they may not reach that 30% because of the side effects from the medication that causes for them. So again, we're going to document that really well in the chart so that we can get approval from an insurance company to have the surgery done. Okay. So I'm going to keep going, and we're now going to talk about lead location. So I mentioned earlier there's different areas in the brain that we can put the DBS electrode, and it's kind of like a little maze in the brain there, sort of, kind of, except we have a lot of experience in terms of how to find the location in the brain that we want to put that DBS electrode in. And there's 3 areas that are most common in Parkinson's. There's the GPI, or the globus pallidus interna, STN, the subthalamic nucleus, VIM, ventral intermediate. Now, the VIM, it only helps with tremor. It's better at helping with action tremor than it is resting tremor, but it can help resting tremor. And because it only helps with tremor, it doesn't help with dyskinesias or reducing medicine or stiffness or slowness, we rarely use that target. The SCN and the GPI target There's pros and cons with each target. You'll likely get benefit with either target that we use. But I'm going to talk about a few things about each target. But when we're talking about a surgical candidate and doing DBS surgery, that's one of the things that our team does. We hash out which area in the brain do we want to put this electrode for this specific patient. There's some centers, they don't do STN versus GPI. They just do STN all day, every day. That's the only target they do. Okay? So again, every center is a little bit different, but we do this approach here at UF. I have 4 different papers here talking about the benefit of STN versus GPI. I'm not going to go through every single one, but I did the review for you very quickly. The one in the top corner that says movement disorders, clinical practice, little red box, that one I'm going to go into more detail because there's actually 3 studies within one review. But first of all, for these other 3, in terms of the first paper with the up in the right-hand corner, GPI and STN, they tied in terms of efficacy, risk versus benefit, both targets. For the one to the left side in neurology paper, the STN target won over the GPI target in terms of preference. And then in the lab study there, STN also won. And in some areas, they tied, okay? So some areas STN won, some areas they tied. So how about this movement disorder clinical practice? So it's actually 3 long-term studies. The first one was the NIH COMPARE study. That was a multi-center study. UF was one of the centers part of that study. And it was a 7-month evaluation of STN versus GPI blinded. Some patients had unilateral placement, which means just one side of the brain. Some patients had bilateral placement, which means both sides of the brain. Some were randomized to GPI, and some were randomized to STN. The VA co-op study was a very large study, and it was actually a 3-year follow-up. They did follow-ups at the 6-month mark, 24-month mark, and the 36-month mark. And then the NSTAT study, that was a 1-year follow-up comparison of STN and GPI targets, okay? So when they looked at different things of GPI versus STN, the first thing they looked at is the UPDRS. The UPDRS is the Unified Parkinson's Disease Rating Scale. So I think a lot of you are familiar with that. That's when the doctors kind of make you do this tapping and open and closing. They check your rigidity and they look at your tremor and they score everything. And there's different parts of this scale too, where there's an interview part where we ask you about your memory and thinking or depression or your handwriting, okay? So the part 1, mentation and behavior, that's when we're asking you about if you have vivid dreaming, how's your memory, do you have any depression, are you apathetic? The part 2 self-report is on activities of daily living. How are you doing bathing, dressing, walking? How's your speech, your handwriting? The part 3, so we have 3 different levels of part 3. Those are different medication and DBS states. So evaluating the person with no medication, so off medication with the DBS on, evaluating them off medication with the DBS off, and evaluating on medication with the DBS on. And then they also looked at walking or gait and posture. And then they also looked at the effect of dyskinesia. So let's see how STN and GPI did. So in terms of all these different areas, the GPI and the STN tied in a lot of areas. So that's why I say, you know, whether you get the lead in the STN part of the brain or the GPI part of the brain, you're going to get some help either way from either target. Now for the STN, it won out in patients where they were off med with the DBS on. It won out compared to the GPI target. And then it won out on the gait and posture. Although there are some other studies that show that GPI has less of a negative impact on the walking. But this STN on here was more looking at a positive effect on the walking. Well, what about GPI? Well, GPI won out in more areas than the STN. It won out on, your on and off evaluation, both with medication and with the DBS on. It also won out in dyskinesias long term. The thing with the STN target is you get more medication reduction in the STN target. And because you reduce medication, you have less dyskinesias. But then long term, as you get further away from the surgery, your Parkinson's continues to progress. And eventually you have to increase those medications back up. And as you increase the medications back up, in some patients in the STN target, it does not suppress the dyskinesias. With the GPI target, you don't get as much medication reduction. But even if you're on the same amount of medication, you tend to get suppression of the dyskinesias. So long term, the GPI is better in terms of helping with dyskinesias compared to the STN target. So the next thing that they looked at is memory and thinking, mood, whether people were tired or not, and then how quickly these targets, programming in these targets, depleted their DBS battery. DBS batteries, I'm going to talk in more detail later on in this talk, but sometimes people have to get their DBS battery replaced. That's another surgery, right? So, that's something they looked at in these studies. So for GPI versus STN, these are the areas that they tied in. They tied in terms of memory and thinking, on the rating scale, on verbal fluency, on both phonetic and semantic, and they tied in terms of people reporting whether they were happy or not. So then what happened with STN? Well, STN helped, one, in terms of the IPG battery use. The STN target is smaller than the GPI target, so it takes less energy to stimulate in that area of the brain. Because it takes less energy, it drains the battery less. So you have less frequent battery replacements in the STN target compared to the GPI target. Well, where did GPI win? Well, with the 36-month co-op study, did a little bit better long-term in terms of memory and thinking. Did a little bit better in terms of verbal fluency than the STN target. People in the GPI target reported less anger than people in the STN target. And then they also reported being happier in one study and not as tired in the other tired. In terms of being tired, I would not, generally I tell Parkinson patients that DBS is not going to help with energy level or how tired someone is in general. Exercise is really the best thing to help with that, believe it or not. And I completely understand. I'm like, I can't exercise because I'm too darn tired, but it actually energizes you. So I'm really glad that you guys do participate with PD Connect, because that's one of the best things you can do in terms of energy levels and keeping you moving. Okay. So next, we looked at, is it different whether you have just stimulation on one side of the brain or both sides of the brain? And, it seemed like in terms of different areas, maybe there was a slight or possible advantage, but it really wasn't statistically clear or significant. But they did see a definite advantage in terms of dyskinesias for the bilateral GPI target. So GPI is better than STN. And then in terms of medication flexibility and stability long-term, the GPI target actually looked better. For ease of programming, the GPI target, it's easier to program. And the reason why is because it's a bigger target, it's a little more forgiving in terms of side effect profile. The STN target is harder to program because it's such a small target. You tend to get into side effects quicker with the stimulation. And also in the STN target, there's a higher incidence of what we call stimulation-induced dyskinesias. So actually, dyskinesias can get worse with STN There is an area in the GPI that can also induce stimulation-induced dyskinesia, but it's easier to avoid, again, because it's a bigger target. The STN target had a definite advantage with medication reduction. So that is an advantage of that target, and especially if you have bilateral leads in the STN. For the unilateral GPI, those were the patients that had an advantage in terms of going longer before getting the other side of the brain done, in terms of length of time. For unilateral STN patients, it seemed like, you know, if we staged them that, you know, within 6 months or a year, they were wanting the other side implanted. Whereas for some reason with the unilateral GPI patients, some of those patients went 2, 3, 5 years before they felt like they needed the other side of the body treated. So those were things that they looked at. In terms of overall quality of life, mood and behavior, off periods, that really didn't seem to be statistically different between whether you did a unilateral or bilateral device. So overall, when the GPI won in terms of dyskinesias, ease of programming, and flexibility with the medication adjustment. And overall, the STN won in terms of medication reduction, reduced battery replacement, better economic profile. Better economic profile because less surgeries in terms of battery replacement, and then the medication in terms of cost of medication. So that's why we say that. But when we look at it all together, we really think the two targets are tied. And it's just, you know, working with your providers to pick which is the best choice for you with all the information that they have in front of them. Now, when we talk about these targets and putting the DBS lead in place, the little green structure there, that's the subthalamic nucleus, and that little purple stick-looking thing, that's the DBS electrode. The electrodes, most electrodes have 4 different levels, and so we're trying to get, you know, 1 or 2 of the electrodes in that green spot because that's going to be the area that we're going to try to stimulate in. And we want it not exactly bullseye, but we want it in a certain area of the subthalamic nucleus. And to try to get the best benefit for each person. Sometimes the leads aren't exactly perfect for different reasons. It could be because of the trajectory the neurosurgeon has to use. It's not that the neurosurgeon did a bad job, but when they do the surgery, they have a CAT scan and an MRI, and they merge that together. And they're looking at the major arteries and vessels in the brain. And they're figuring out the trajectory that lead has to go to penetrate through the brain to get to the target they want the lead to be in. And sometimes there's a major vessel, whether it's an artery or a vein, that they have to move the trajectory of the lead so they don't nick that artery or vein. Because if they nick it, then that's a stroke, okay? So, you know, when we talk about placement of the lead, you know, sometimes it may not be exactly perfect or pristine because we're trying to avoid causing another problem that's going to be worse, okay? And just because a lead isn't exactly bullseye, that doesn't mean that lead's not programmable, and that doesn't mean that you can't get some level of benefit from it. We have to do trials of programming before we decide, okay, this really, we're not going to be able to get this to work, okay? But depending on where that lead is, it changes in terms of side effect profile, okay? In terms of whether you get early paresthesia, which is like a tingling sensation, or muscle contractions, or slurring of speech. Remember, speech and swallowing centers are right next door to these structures. So when we stimulate the field outside a certain area, then we'll cause slurring of speech or a swallowing issue or some other, you know, sensation that you don't want to have, and so then we'll have to lower that stimulation. So this is another example of the lead being either placed anteriorly or posteriorly to the STN target. Now, when we look at the GPI target, so and this is still STN, superior and inferior. I'm going to go ahead and go to GPI. GPI, a lot bigger than the STN, okay? You have your GPI, then the GPE, and the putamen. If we spread the field, you know, into GPE, sometimes it helps a little bit with symptoms, but the further we get into that GPE, closer to the putamen, then we get into like a muscle contraction. So that wouldn't be acceptable. You know, that's not a good trade-off. Getting rid of your tremor and then now we make your arm do a weird thing. So that's not good either. And again, depending on where the lead is within the target, that can affect benefit versus potential side effect. And when we first do testing or programming, the very first visit, we test each level and we go as high as we can go so we can see where that side effect profile is. And that tells the person who's doing the programming if that lead is medial or if that lead is lateral. You know, we kind of get an idea of exactly where that lead is in the target on how you respond and what kind of side effect that we see. Okay. So now I'm at another tip of the iceberg, which is the surgery itself. So before I move on, do we have any questions? I don't.
I think you've answered most of the questions in terms of placement and unilateral versus bilateral. There was a specific, at Fixel, is it always the same target bilaterally? I think you answered that, yeah.
It's usually we do the same bilaterally, but we've had some patients where we put in like a lead in the SPN, and we went to program that, and the person didn't do as well. So they had enough benefit. We didn't want to move the lead on that side of the brain, but for the other side of the brain, we picked GPI because they didn't do as well as we thought they were going to do with SPN. So we did GPI on the other side. We've done all kinds of different. To go into all the scenarios that we've done, I think that would make your head spin. But yeah, we've also put two leads on the same side of the brain in different targets here as well for specific reasons. Okay. All right. So I'm going to move on to DBS surgery. So there's different types of batteries. There's what we call single chamber batteries where only one DBS electrode can fit into that lead. So if you have a DBS electrode on each side of the brain, then you would have to have two single batteries. There's also dual channel batteries where two leads can be connected into one battery. There's a company that has a quad channel battery. I just said a moment ago that we have some people where we'll actually put two leads on the same side of the brain. And in some of those patients, we'll put in a quad battery. There's also now a longer electrode that instead of 4 levels, it has 8 levels. And that lead actually requires 2 connection spots on the battery. So that's another reason we may use the quad battery. We may put one lead on both sides of the brain, but extra long lead, which means we need 4 ports to connect to. So there's all kinds of types of DBS hardware that's available. And so when the surgical team is trying to decide what you're going to need, they're trying to keep that in mind in terms of the future, what we need to set up for this individual. Oh, I don't know if my Epic keeps trying to come back up. I don't know if you guys can see what's coming up on my screen like I can. Are you still just seeing the PowerPoint?
Yeah, no, we don't see what's coming up for you, so you're all
okay, good. Good, because I didn't want you to see that, so that's good. Share screen working just like it should. All right, so there's different parts of the component. So number 1 is going to be the actual electrode and the first part of the extension, which is where that number 1 is at the top of the brain, and it kind of stops right behind where the ear is. And then number 2 is the extension or connecting cable. So that's where we connect in right behind the ear. So some people have a little extra bump kind of behind where the ear is. And then that goes down to the DBS battery. So that's going to be the neural stimulator. Some people call it an IPG, implanted programmable generator. And then number 4 would be the patient programmer, which each company has different programmers. Depending on the battery you have will dictate the type of patient programmer that you will see. And so this is kind of like the whole system together. And then stages of surgery. Again, it's different at every center. All right. So you would have to speak with your neurosurgeon to see how they do their staging at their program. Some places do leads both at the same time. We don't do that here at UF unless it's a very young child. When you do a simultaneous surgery, they make a burr hole to access one side of the brain. And then when they're ready to do the other burr hole, what happens is once they make that second burr hole, the brain will shift a little bit. And that shifting of the brain will change the targeting that you were using from that MRI and CAT scan. So it affects your ability to target the area of the brain that you're trying to target. And so that can result in that second lead not being as pristinely placed as the first lead. Also, when you do simultaneous surgery, it increases your surgical time, and increased surgical time increases your surgical risk in terms of infections or confusions or other things. So that's why here at UF, we prefer not to do simultaneous if we can avoid it. Some institutions will do rapid stage where they'll put a lead on one side of the brain, wait 2 to 4 weeks, put a lead on the other side of the brain, then wait 2 to 4 weeks and put in the DBS battery and connecting. And then sometimes we'll do what we call here standard stage or delayed stage. So if we have concerns about someone's memory and thinking, their walking or swallowing, then we may stage the surgery out. So we only work on one side of the brain. We put everything in for that one side. We program them for 5 to 6 months. And then if we decide to proceed forward for the other side, then we'll set that person up for that surgery. So again, it's different every place. Stage 1 is what we call the DBS electrode implantation. Stage 2 is when we connect everything together. And then here's some pictures. So not all centers use a halo. There's a couple of different types of ways that they have one halo that goes all the way around. There's one where it's a surgical tech where it just kind of, they bolt it just on the side of the head. But here at UF, this is what we do. And so we get an MRI the day before the surgery. And then the day of the surgery, we put this halo on. And then we take the person to a CAT scan. And so that allows us to merge the CAT scan images to that MRI. That allows us to see the vessels that we want to avoid, that we don't want to nick as we're passing the lead in. It kind of gives us the ability of figuring out where the regions in the brain that we want to target, where those are in space in relation to that halo and those two imaging. So it helps us with placement of the lead appropriately. And so then here in the bottom corner is our surgeon. So on the, you see like this little plastic drape next to him. On the other plastic drape is our neurologist. And he's doing what we call microelectrode recording. So as they pass the DBS electrode into the brain, they hear like a static, kind of like static from like a radio, right? I'm glad I'm talking to you guys because when I talk to, you know, my students with physical therapy and other areas that are young, they don't always know what static on a radio is with the digital age now. But they hear static, and that static noise, it sounds differently in each region of the brain, okay? So they can tell which region they're in by the static noise. And behind this computer here, where you have everyone looking, behind this computer is sitting someone sitting behind there, and they're entering in the areas where the neurologist is hearing the sounds of the different regions. And so then all that information that they put into the computer, it then shows the trajectory of the lead in that patient's brain. And so here they are with that first pass, looking at where the trajectory is. Is it in the area of the brain that I want it in, or do I need to move it, you know, so many millimeters this way, so many millimeters that way, and that helps them to try to get the lead exactly in the area of the target that they want. For this surgery here at UF, the vast majority of our patients, we have them awake. And that's because as we're, you know, putting the leads in position, then we're going to test them moving their arms and legs to see if we can hear an increase in that static noise. And that also helps us verify that we have the lead where we want it to be. Also, if they have tremor, we can see the tremor and we can see if there's an impact and a decrease in the tremor. It helps us in terms of confirming that it's where we want that electrode to be. Because having the electrode where you want it in the target, it's like real estate. It doesn't matter how good of a programmer I am. If the DBS electrode is not in good placement, we're not going to have a successful outcome. So just like real estate, location, 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 okay? Do you want, your house on the beach, or do you want it in the swamp? Okay, makes a difference. And then for the stage 2, we have people asleep. We don't want them awake during that. And I'm not going to show you any pictures of that, so you don't have to worry about that. Now, there are some centers that do a sleep DBS, and that's completely fine. We've learned over the years the best areas in the targets where to put it. And it's individual neurosurgeons' preference whether they're going to do a sleep DBS or not. They have to have a special intraoperative magnetic resonance imaging, so not all centers have that. Here at UF, we have chosen not to do that. We prefer the awake DBS, but there are some centers that do a sleep DBS, so that you know. And then there's also focus ultrasound and Parkinson's. Because my focus of this talk is DBS, I'm not going to talk about that, but I will tell you it is FDA approved, stage bilateral, for Parkinson patients. However, that doesn't mean it's covered by your insurance. That varies from state to state and from plan to plan. It is not universally covered by Medicare. So there's some states where, even though it's FDA approved, you can't get it as a Parkinson patient. It has a higher incidence of approval for essential tremor, but not right now nationally in terms of Parkinson's. All right, so before I move on to vendor comparison, do we have any questions?
Yes.
Okay.
Where do we begin?
Well, I have a question. There was one question about, are there any statistics on failed surgeries or some of the complications? I don't know if you're going to go into that. And then what are some of the common complications?
I will be going into benefits and side effects in a slide coming up, so I'm going to save that one. I don't have any hard statistics for you. I can tell you here at UF, I think we're like 6 to 10% in terms of like infection or stroke or, some other complication rate. That's considered high in medicine, because you don't want any complications. But, there's a lot of programs, they don't necessarily track those or not. They may track them, but they don't publish them.
Right.
So it's hard to know that.
Sure. What about, are robotics used for any part of the surgery?
Not really. I mean, yes and no. I mean, in terms of like the electrode going down, let me see if I can go back. So right here, there's this little device right here. And so as the neurologist, can you guys see my little cursor as I'm moving it?
Yes,
okay.
Yes.
So the neurologist, they're moving this dial at a slow rate to go down into the brain. And so that's kind of like a kind of a robotic part of it, but no, I mean, we don't have like, beam me up, Star Trek stuff doing the surgery for you. It's mostly the neurologists and neurosurgeons doing all the work. Okay. Any other questions?
We'll move on and then we'll get back to that.
Okay. So vendor comparison. So I talked earlier, we've got kind of some 3 companies duking it out. Medtronic was the original company here in the United States, and they were kind of the big guy on the block for many, many years. And then Abbott, which originally the first name for Abbott was ANS, Advanced Neuromodulation Systems, got bought by St. Jude's, so it became St. Jude's for a while, and then most recently was bought by Abbott. So when I'm talking about Abbott, I'm talking about ANS, St. Jude's, and Abbott. They're all kind of together the same system. And then Boston Scientific. So Medtronic really, they had some advances in some of their technology, but for a while it stayed the same for, almost 10 years. But then when Abbott or St. Jude's, they came along, they developed directional leads. So these are segmented leads so that you could maybe turn off certain sections and stimulate in other sections so you can try to avoid side effects. And this kind of lit a fire under Medtronic to have more advancements in their system. So, you know, that's a good thing that these companies, they keep jockeying in terms of like who's ahead. So I think there was a period of time where Abbott was slightly ahead because it was the first one with directional leads. Boston came out, they had like a fractionalized lead as their first electrode, but then they moved on to segmented leads. And so again, now all three companies, Medtronic, Abbott, and Boston, they all three have segmented leads. Now, Boston Scientific has the longest segmented lead, with 8 levels. That just came out in the last year. So they're kind of a little ahead in terms of that capability. In terms of the batteries, all three companies have rechargeable batteries. There's pros and cons in terms of the charging with all three companies, but it's still, all three have rechargeable. In terms of the patient programmer, the programmers, you know, I would say that the majority of patients do not have a problem with using a programmer from any of the three companies. Every once in a while, with all three companies, there is a patient here or there that just gets a little flummoxed with any type of technology and may need a little extra teaching in terms of how to use their patient programmer. They're all FDA approved for STN and GPI and VIM. The Abbott is now GPI approved as well. I forgot to update that slide there. They all have variable frequency. Again, for a while, they did not have independent variable frequency. Now they do, you know, so as one company improves something, the other company catches up, all right? In terms of the patient programmers, how the clinician programmers, they all have very nice, easy program profiles for someone like me, a DBS programmer, to use. In terms of AI, that's like the biggest thing that some people ask me about now. Medtronic has what's called adaptive or closed loop stimulation. And so when we say adaptive stimulation, most of the DBS devices, it's just one kind of setting. There's no variation with it, regardless of whether you're in an on or off medication state. Medtronic has the capability where not in all patients, but in many patients, we can see an area on the brainwave form called a beta peak. And that beta peak can equate to Parkinson's symptoms. So if that beta peak is high, that means that you have Parkinson's symptoms like stiffness, slowness, you know, walking problems. And if we're able to lower that beta peak, that equates to improvement in Parkinson's symptoms, like improvement in tremor and walking and other things. The way we improve that beta peak, the lower the beta peak is either with Parkinson medication, that'll lower your beta peak, or with stimulation. And so if we mark that and then we put in certain parameters, then the device will adjust the amount of stimulation that you get based on where you are with that beta peak. It still takes multiple programming sessions, even with the adaptive, to get it just right. It's not like I press a button and it immediately works, okay? Even with the adaptive, even with the AI. The Boston Scientific device, now they don't have adaptive stimulation, but what they have is what they call the Lumina AI programming. And what that does is we put in that individual's imaging of the lead in their brain, the MRI imaging and the CT scan imaging. And then it will actually show us the structure with the DBS lead in it. And then we can put that into the computer, and then it'll actually give us a recommendation of disbursement of activation of what contacts to activate. And that doesn't mean the work is done. I mean, that's just one part, how to activate which component of the electrodes. There's still other factors that someone like me has to program, but it certainly does help. And you can also use that Guide XT. Guide XT is the structures that you see there. You know, seeing the STN and seeing, you know, the other structures around the STN. That's called Guide XT. That's what they call that program. And the other thing that they have that the other systems do not have is what's called onic stimulation. So it's just a different way we activate the electrodes and the battery. And that can, again, help steer the current. So we can try to steer it and stimulate the areas of the brain we want to stimulate in, and then avoid the areas of the brain we don't want to stimulate in. The only company that has true remote programming, where like telemedicine remote programming right now, is Abbott. Now that's if you have a provider who's willing to do remote programming with Abbott. I would tell you personally, as a programmer, if I'm actively trying to program someone to help with their rigidity or their walking or their tremor, I want to do it face-to-face in the office. I don't want to do it remotely. Now, if I've optimized the settings and I'm just checking the impedances or checking the battery life, I don't mind doing that remotely. But if I'm actively working on finding the best settings for someone, I want to do that face-to-face. So why do I want to do that face-to-face? Well, say you have say you have tremor and you want me to help with your tremor. Well, sometimes there's a delay in response to the stimulation. So say I adjust your settings and the tremor's the same regardless what I do with the setting. Sometimes I can actually improve the rigidity before I can improve the tremor. So if I'm able to find a setting that the rigidity is actually better, and I leave you on that setting, then 3, 5, 7 days later, that tremor may finally get captured. But rigidity is what I feel when I check your wrist or I check your elbow. That's how I feel the rigidity. I can't do that through telemedicine. I can only do that in person. So that's why I would want, you know, active programming to be done face-to-face rather than remotely. Now, remember what I said earlier. I'm going to go back real quick. Remember where I said it used to be not all companies have rechargeable batteries. It used to be not all companies had directional stimulation or variable frequency, but now they do. Well, guess what? I bet you in the future, all companies are going to have remote programming. Okay? So, you know, when you're trying to pick what's the best company you use, well, I think the best company you use is the company that the physician who's going to be doing your surgery and the person he's going to be working with to do your programming, whether it's a neurologist or a nurse practitioner or physician assistant, using the device that they have a comfort level in programming. That's the most important, okay? Because say you go and you listen to a talk from X company, and because you heard X company's talk, that's why you want to get that X company's device. But the person that you're going to be going to doesn't have a comfort level in programming that device. It's going to be a hard going for you, okay? So those are things to keep in mind. When you're using adaptive stimulation with the Medtronic device, we're programming towards the physiology in the brain. When you're using the Lumina program in the Boston Scientific device, we're programming towards the structure or the targeting in the brain. In the end, whether you have Medtronic, Abbott, or Boston, you're going to get benefit in terms of the Parkinson's. Okay, so I just want to, put that there. This is an example of the beta that we're following. So this is showing as we go up on the stimulation, we're suppressing this beta. See how this line so this shows that potentially constant stimulation with the adaptive stimulation chosen on that patient is going to be successful and helpful for that person. All right. So now I'm going to talk about DBS programming. But before I do that, do we have any vendor questions? Nope. Okay, good. So DBS programming. All right. Every center has their own individualized programs in terms of designating programmers. A programmer could be a neurosurgeon, a neurologist, a fellow neurosurgeon or a neurology fellow, a nurse practitioner, a physician assistant, or even a nurse, okay? Most of the time, learning how to program is on-the-job experience. There's not a special school that you go to learn DBS programming, okay? And then programming the neurostimulator, it's not like turning on a light and it works immediately. It takes time, okay? Patients will have to return to clinic a few times. Sometimes it can take 6 to 8 programming sessions to get things just right. When I say just right, it's not just right in terms of suppressing that tremor, but not slurring the speech or whatever that balancing act is that we're doing for someone. Sometimes 100% tremor suppression is impossible. I have some patients where the setting that helps their tremor causes unacceptable slurring of speech. And when we lower the setting to get away from slurring of speech, then the tremor comes back. So it's this balancing act between how much tremor control do you want and how much speech side effect are you willing to have. Now, it's a little easier for us to avoid side effects because of the directional stimulation capability we have and all the different tricks that we have that we didn't have, say, back in the early 2000s. So in the early 2000s, there was about 54 to 64,000 combination of settings. Now there's over 1 million combination of settings because of all the different things that we can do now. So it takes time, okay? In terms of the settings, you know, we can choose which leads we activate and how we activate them. It used to be that you had a choice between voltage or milliamps. Now all the systems are now milliamp only. That's driven by the battery type that's used. Pulse width is the density of the field. Frequency is how fast that field is given. The beat of that field. Directional stimulation is where we're turning off certain segments to try to steer that current where we want. Interleaving subprograms and area stimulation, that's when we stimulate in multiple areas simultaneously. And sometimes that's a trick that works better for people. Cycling is when we turn the device on and off at certain intervals, and sometimes that's the trick that works with patients. And we already talked about adaptive and using AI. So when we adjust or when we activate the different electrodes, we used to talk about it in terms of monopolar and bipolar. This was before we had segmented leads. And so a monopolar stimulation array is more of a spherical stimulation array. It has more robust effect, especially if the lead is well located. But then if we're getting into speech side effect and we still want to stimulate in that key area, but not get into that side effect profile, then we may do what we call a bipolar setting, where one part of the electrode is activated negative and the other part of the electrode is activated positive, and that makes more of an elliptical type stimulation array. Here I got a little triangle, but you get the idea. One side is fatter than the other end, and then that helps us pinpoint that stimulation to try to avoid a side effect but still get benefit. With directional leads, we can actually not activate it spherically, and we don't have to necessarily do like a bipolar like that. We just turn off a segment. So this A picture, this is the green area is the STN. This red area is the internal capsule. We don't want to stimulate here. That could cause like a pulling sensation that's not comfortable. And you see how this little red part is going into that internal capsule. All right, so what do? So we turn off, one segment of that lead, and what that does is it kind of forces that stimulation more towards the STN, the area where we want to stimulate and avoid that side effect profile. Again, that takes time in terms of kind of like not entirely trial and error, but yeah, trial and error of these different combinations. And then the other thing that I had spoken about earlier is, this pulse width and frequency and amplitude. Higher numbers doesn't mean better results. Higher numbers may cause side effects. So I will say my ladies are a little bit better about that. It's usually my men who come in and they say, I need the setting higher. No, you don't need it higher. We need to, finesse it a little bit in terms of, where the levels are. The best analogy I like to give is it's kind of like a combination lock. So the little combination lock, you dial it one way, you dial it the other way, and you dial it the other way again, you open that lock. Well, we're trying to dial in the right numbers for your brain. And the right numbers isn't what's right for Mr. Smith or what's right for Mrs. Jones. Everybody's brain responds differently, and we have to find out what numbers your brain likes. And so it doesn't matter if you put in higher or lower settings in that lock. You've got to put in the right combination of settings, okay? So that's part of the programming as well, putting in the right combination of settings, putting in the right contacts that are activated. And when we talk about interleaving cycling or interleaving and cycling, that's also subprograms and area stimulation. The term changes depending on the company's device that you're using. But that's where we may be stimulating in two different areas, and it kind of goes back and forth between those two areas. Sometimes some patients, if you just stimulate in one area, the brain kind of acclimates to it. So it may, work for like 2 weeks or 3 months, but then it trails off that benefit. And it could be that we need to kind of switch that setting so it goes back and forth so your brain doesn't acclimate to it. Same thing with cycling, where we have it on for a set period of time and we have it off for a very short burst and we have it turned back on. It's one stable setting, but we automatically have the device turn on and off in a very short period of time. Or we can combine both of these. It's rare that we have to use these. I would say 2 out of 10 patients benefit from this type of stimulation. That means 80% of patients do not benefit from this type of stimulation. But if you're a patient that we're already having trouble with programming, and this is what saves you from having to go back to surgery, or this is what gives you the level of benefit with less side effects, then it's great that you're one of those select people that this type of advanced programming can be helpful. And then we have that adaptive stimulation that I talked about, where, traditional stimulation is just an open loop. There's no reaction from the device in terms of your medication state, whereas with the adaptive closed loop stimulation, it's going to be adjusting whether you're asleep, whether you're off med or you're on med. And it does help in some patients. It's not right for everybody, but the good thing is, again, it's something that's available that we can use to help people. It's not that you turn it on, it works right away. It can take, about 3 or 4 programming sessions to kind of get that right. And before we can even get to that, we have to have a couple of programming sessions beforehand. Well, what do I mean by that? Well, to be able to set up that adaptive, we have to first get what we call a timeline. So we just kind of have to listen in, and so we can see the reaction to the brain waves with your medication with the DBS electrode in place. So we have to first set that up. We have to send you home, and then we have to bring you back, and then we look at those tracings. And then we can set up the limits of that area that we're monitoring in terms of reaction to stimulation and to medication. And then we can activate the actual adaptive stimulation. And once we activate the adaptive stimulation, there's different ways we activate it. We have what we call single threshold or dual threshold. I'm not going to go too deep into that, but some patients respond better to single threshold. Some patients respond better to dual threshold. And we have to send you home and let you try it. And then you come back and you tell us how it was. And then we make adjustments. So it may take, a few visits of getting that adaptive AI stimulation just right for an individual. So that's the DBS programming part. And now I'm going to get into risk and benefits. But before I do that, do we have any questions about DBS programming?
I think you covered it well, really, really well. There were some questions about, how some people may have gotten the DBS, but they still feel like they're having such trouble. And I think that speaks to there are over 1 million different ways to be programmed, and look at how complicated it is. So what you want is a really, really good programmer, which is why Pam is on today's show. Thank you very much. You're on again.
Right. The other thing is sometimes I've had some patients where they had benefit from their DBS for like the first 2 or 3 years. And then as their Parkinson's progressed, they develop symptoms that the DBS isn't going to necessarily help with. And they feel like the device isn't helping them. And I've had, some patients where it's time to replace their battery. And they're like, why should I replace the battery? It's not doing anything for me. And I don't fight that. And I say, okay, well, let's do this. Rather than waiting for the DBS battery to die, just turn it off. And if you don't turn it back on, we won't set you up for surgery. I haven't had a patient yet who hasn't turned their DBS battery back on and call me back and say, I need the battery replaced. Okay. So it probably is helping you. It's just not helping you with everything you want it to help with. There are some people that the DBS stimulation can make something worse, and the best way to figure out, is it the setting that's making me worse, or is it related to my Parkinson's and the DBS just isn't helping that? And the quickest way to figure that out, again, turn the darn thing off. If you turn it off and your speech gets better, turn it back on. And if your provider gave you a range to adjust your device up or down, then dial it down a little bit. And then your speech may not be as bad. The tremor may not be as good. And again, you can give that feedback to your provider, and then they can try other strategies. So I'm going to go into the risk and benefits. We're getting close to the end. I think I am a little bit past an hour, but if you guys are okay with hanging in, I'll keep soldiering through. Okay, we got a thumbs up. So surgery. Every surgery has a risk. And of course, the big bad D word there is death is there, right? So any surgery, there's a risk of death. I mean, thankfully, here at UF, we don't have that happen very often. I'm not going to say it never happened. I think I've been here for 20 years, and we've only had 2 deaths in that period of time. So it is a risk. Also, bleeding inside the brain or a stroke, that can happen. The older you are, that risk increases. Seizures, again, we're, doing a brain surgery. There is a risk of seizure activity. It's rare, but it can happen. Pain at the surgical site, headache, those are kind of temporary. They're not like long-term effects that you have. In terms of after the surgery, just penetrating the frontal lobe or even the stimulation, some people can have a worsening of depression. Doesn't happen very often, but it can happen. They may have worsening of anxiety. Again, not everybody, doesn't happen very often. They can have problems with impulse control issues, compulsive smoking, compulsive gambling, on the computer a little bit too much. Most of the patients have impulse control issues. And don't forget, this can also be caused by medication, but I'm mostly talking about DBS. Most of those patients with impulse control issues, whether it's hypersexuality, gambling, smoking, whatever they're doing, they're happy about it. They don't see a problem in it. Usually the person that has a problem with it is the spouse, okay? And usually it's the spouse that's reporting, hey, this is going on. And then we have to figure out, is this medication caused? Is it from the surgery? What can we do about it? Okay. And here at UF, Dr. Foote, who's our neurosurgeon, and Dr. Oken, who's our neurologist, they made a little mnemonic called DBS and PD. And so D in the DBS does not cure. So DBS is not a cure. It's a treatment, just like your medication is a treatment. Often bilateral procedures are needed, especially if we're talking about walking or balance issues. Just like you need 2 legs to walk with, oftentimes to treat walking issues, we need a lead on each side of the brain. It can smooth out your on and off fluctuations. That doesn't mean it takes away on and off fluctuations. Some of my DBS patients still have on and off fluctuations, but what they'll tell me is that their offs are not as severe, or their highs, those on highs, are not as severe. Now, some of my patients, they miss that high that they get with their on. Not all Parkinson patients will get that, but the patients who do, you'll kind of know what I'm talking about. You take your medicine, 30 minutes later, you're like, ooh, you know. So that it smooths out not only the off, it smooths out the on. And so some patients, it makes them more level. And then some patients feel like when they're more level, they feel like I'm not getting an on state because they're not getting that on state that they had before DBS surgery. But that's like the goal of the surgery, is to smooth that out, to try to level it off. So sometimes it's a missing that level that they had before. It can improve tremor, stiffness or rigidity, slowness of movement, dyskinesias in most cases, and but it doesn't necessarily make them all go away. And I've kind of already talked about that. Okay. Sometimes when you're trying to make it go all the way, then we get into a side effect with the stimulation. It never improves symptoms that do not respond to your best on. So for example, if you have walking problems in the on medication state, the DBS is not going to help with those walking issues. If you have improvement in your walking with medication, then you have a chance, not a guarantee, but a chance that DBS will help with those walking issues. Okay. DBS is better at helping with slow, short steps or freezing of gait, not so good at helping with balance, and doesn't help with festination gait or propulsion of gait. So this fast forward running gait, not as good at that type of gait pattern. Okay. Programming visits, usually you have to do several visits to get everything just right. And then the last thing, you know, you can decrease medications, but only some of the time. Not all patients are going to be able to decrease their medication. So in terms of some things the DBS cannot help, I got these two guys here. So I want you to kind of look at each one, and I want you to kind of think in your head, okay, which one of these guys can DBS help with? And I'm going to tell you. So Al, number one, DBS is not going to help because he's just angry, and we can't help with people that are angry. Al, number two, maybe has a little cervical dystonia or, you know, something going on there, and DBS can potentially help with that. Okay. So 3 things the DBS is not good at helping with and can sometimes make worse: memory and thinking, speech, and walking. We've talked about the memory and thinking. DBS patients over time Parkinson patients over time can develop problems with their memory and thinking, and DBS doesn't slow that process down. Sometimes having a brain surgery can, you know, bring on memory issues that you didn't have before. It doesn't happen in very many patients, but it is a possibility. So you need to know that's a risk of the surgery, and it won't help whatever the normal progression of cognition issues in Parkinson patients. Speech. Parkinson patients develop problems with their speech over time. DBS will not help with whatever your baseline speech deficit is. So if you turn the DBS off and your speech is exactly the same with the DBS off, then you need to work with speech therapy. The DBS isn't causing that softness of speech or the stuttering if you're having that. It's just not helping it. Now, if you have slurring of speech from the stimulation, you turn the DBS off and that gets better, well, then you got to go back to the programmer and they'll help you with that. So we can only help with speech in terms of a side effect we are causing with the stimulation. And then for gait and balance, if medication helps with the gait, maybe the DBS will help with the gait. I would say that there are some patients that DBS does not help with the walking, but it also does not worsen the walking. A rare amount of patients, the stimulation can actually worsen the walking. So how do I figure out a walking issue is a Parkinson symptom that the device is not helping with versus a walking issue the device is causing? I ask the person to turn the DBS off. And if the walking issue improves with it off, then there's something about that stimulator setting that the brain doesn't like, and we need to try something different. Now, turning it off in the office isn't always good enough, because you can have a residual benefit or a residual side effect that can last as long as 10 to 12 hours after turning the device off. So what I'll ask my patients to do is turn the device off before they go to bed. So the majority of the time that it's off, they're sleeping. And when they wake up in the morning, before they turn it on, walk around. Is the walking better with the device off? Then turn the device back on. Did the walking get worse again? Then that's going to confirm that it's the stimulation causing the problem versus the Parkinson's itself that the device just is not helping with. So we kind of just talked about all of these things right now. We did all that. Okay. And then speech and swallowing. So sometimes, you know, the DBS may affect speech or swallowing. When we stage people, you know, 6 or 7 months in between sides, it's a little easier to figure that out because, you know, I'm only working on one side of the brain. And then, you know, if I cause a speech effect, I know it's that side of the stimulator that's causing the problem. But if we have people that we put 2 leads in around the same amount of time, and now they have slurring of speech or worsening of their swallowing, well, is it the right brain stimulator or the left brain stimulator causing that? And again, I can't necessarily turn it off in clinic because there's this delay. So, you know, I send them home with homework, okay? And so I say, okay, both are on and you're telling me this is worse. And I turn them both off. Maybe it's better, maybe it's not better. All right, if you figure out whether it's better or not, then I want you to do a trial of one side on and one side off and vice versa. So maybe it can help me figure out which side of the brain is causing the issue, and then I can program around it. In terms of adjusting it, patients will have programmers. So this is a programmer for Boston Scientific, and it will be changing soon, so it's not going to look like this. But patients have the ability to go into the stimulation, and then for the left side of the body, they can adjust the setting either up or down, and then they can move this toggle over to the right side of the body, and again, be able to adjust the strength of the setting up or down. When you're adjusting the setting, you're only adjusting one component of the setting, but at least that's one component you'll have a little control over. And all devices have groups or programs. So the Medtronic and the Boston device, they have the ability to give you up 4 different settings that you can try in between visits. Abbott has as many as 16 programs that you can do. That's overload. I don't think I've ever had someone that's had 16 programs at one time, maybe 8 max. But in the end, you have options to try in between visits if something doesn't work quite right. All right. For the swallowing, you know, if someone's reporting they're having worsening of their swallowing, you know, that could be the Parkinson's, or is it the setting? I usually have them schedule 2 different swallow evaluations, one with the DBS on and one with the DBS off, so we can compare it. If the swallowing issues are the same with the device off versus on, then they need to work with the speech therapist and swallowing exercises. If the swallowing issue is better with the DBS off, then it's on to the programmer to maybe try some other settings to not get into a speech side effect. Again, it's a low amount of patients that will have that problem. My Epic is trying to come up again. Let me get it out of the way so that I can see my screen. Okay, here we go. Sorry. This computer has a mind of its own sometimes. Okay, so now we're going to move on to frequently asked DBS questions. This is the last portion. But before I move on, are there any questions I need to review?
I think this is a great time to keep going.
Okay, here we go. So how long does a neurostimulator battery last? Okay, there's primary cells and rechargeable batteries. And also in terms of benefit. So typically a primary cell battery is going to last 3 to 5 years. However, it depends on the neurostimulator settings. You know, sometimes, you know, if you require higher stimulation, then the battery is not going to last as long. Once you have stable therapeutic settings, then an estimated longevity could be anticipated for the device in terms of when should we plan to replace it. The shortest battery life that we've had here at UF was 7 months, but that was in a patient who had a different diagnosis than Parkinson's that typically requires very, very high settings. The longest primary cell that I've had last is 10 years. Therapy benefit can vary over time as well, with these batteries, and the lower the battery gets, when you get near the end of life, then you may lose some of that benefit because we need to replace the battery. Most companies now have rechargeable batteries, but that means more work for the patient. So instead of putting it in, you don't have to worry about it with the rechargeable batteries, anywhere from once a week to several times a week. You would have to put a device over your chest where the battery is to charge that battery up. The Abbott device, their battery is called the Liberta RC. The FDA lets them market that battery as 10 plus years. What that means is that 10 years, if they're not having any issues with charging the battery, they don't replace it. They just keep it in and keep on going. That battery could last 15, 20, 25 years. Boston Scientific, all of their batteries are marketed as 15 plus years, which again, that means that at 15 years, if there's no charging issues, they don't replace the battery. It may last 20, 25 years. Medtronic, the Activa RC battery is shut off at 15 years. The FDA made Medtronic do that, but with their newer generation Percept RC, it's 15 plus years like those other company batteries. So can a DBS patient scuba dive? Well, I have some patients that scuba dive. And so you can, but you can't go below 33 feet of water. And same thing with hyperbaric chambers. There's only at a certain ATA that you can have the hyperbaric chamber set up if you have a DBS device. What about swimming? So for many, many years, we didn't really realize that DBS could affect swimming because we don't typically ask our patients about swimming. But then there were a couple of patients that reported that were avid swimmers that their coordination was not as smooth as it was before DBS. Now, I will tell you, so there's a couple of just case reports of people who have reported worsening of swimming after DBS. But I have had patients, after this came to light, I started asking some patients, do you swim, avidly? I'm not talking about doggy paddle. I'm talking about someone, freestyle, doing Michael Phelps, okay? So I started asking my patients, and I've had some patients tell me their swimming actually improved. And then there are some patients that say the coordination isn't as good. Long story short, it's wise for anybody, whether you have Parkinson's or not, to don't swim alone. Have someone that's there with you. So if you do get into trouble, they can help you, okay? And there's no studies that look at swimming and DBS in terms of the amount of patients that have improvement in swimming or don't. But it is something that we need to look at. Can patients lift weights? Okay, so I told a lot of my patients, once everything heals and we're not worried about infection, you can lift as much as you want. Until I had one young person in his mid-20s, and he went back and started lifting very heavy weights. Now, I'm talking about Arnold Schwarzenegger lifting weights. And he had some leakage of cerebral spinal fluid around his cranial cap. It really scared him, and he showed us, and he said, oh, crap, and we said, oh, crap. And so that's when we started telling patients, yes, you can lift weights, but just not bearing down very heavy weights, and no over the head, heavy, very heavy lifting. Now, diathermy is a special type of heated ultrasound or therapeutic ultrasound. A lot of physical therapists or chiropractors will use diathermy, and diathermy is not safe if you have a DBS device, so no diathermy. In terms of radiology, you can get a CT scan or an X-ray, no problem. Regular ultrasounds, like checking to make sure if you're pregnant or if you have like a kidney stone or checking your heart, those types of ultrasounds are completely fine. The heated ultrasound are the ones you can't have. Mammograms are fine. You just have to tell them you have a DBS device in place so they don't press, the battery in the chest. DEXA scans are completely fine as well. But what if you need to get an MRI? Well, not all imaging centers can do an MRI. So you'd have to find an imaging center that can do MRI in DBS patients. Usually your local DBS provider can tell you, or you can talk to the rep for the type of battery that you have, and they can tell you the closest imaging center. And prior to going for that MRI, they have to check your device and make sure it is safe for you to get that MRI. If your impedances, which is like the electrical integrity of the whole system, if they're out of a certain range, then you cannot get the MRI. So you have to have an eligibility form filled out for each and every MRI that you get. And then what if you have to have a surgery or a colonoscopy? Because, you know, as we get older, we get to do fun things like colonoscopies. So you should turn your DBS off during the surgery or procedure. Your provider's going to want to monitor your EKG tracing, and the DBS can cause interference in monitoring the EKG tracing, so you want the DBS off because of that. And then the other thing is that we prefer that the surgeon use bipolar cautery, and we want the DBS to be off if any cautery is going to be used. Cautery is what they use to stop any bleeding as they're doing the surgery. So, you know, they can't wake you up in the middle of the surgery to tell you to turn off your DBS. So turn it off before the procedure or the surgery. And then once monitoring is complete, you can turn your DBS back on. And then, can I stop my Parkinson medication? Everyone wants to stop their pills. I want to stop my pills. I get it, okay? However, DBS and Parkinson medication, it's like a marriage, okay? You've got to have a good marriage between the medication and the DBS device. It's not very often that Parkinson patients can completely stop their medications, okay? Stopping your medications is kind of like a divorce. Sometimes it's good, sometimes it's not good, okay? So, you know, you just want to work with your DBS provider and see, you know, what you could do in terms of lowering, but completely stopping is probably not a good idea. And again, I'm sorry I ran over. This is just a tip of the iceberg. Like I said, I could go on and probably talk until 9, 10 o'clock. I'll go ahead and here's my references. And then we'll finish up with any questions that I have not answered yet.
All right. Wow.
This was amazing. We've had people come and talk to us about DBS before, but we've never had the perspective of the programmer. So we really appreciate this. This was lovely. Thank you, Pam. Did you have any
My
questions?
pleasure.
No. Is there a way that people can contact you? Or I do have questions, but do you want to stop sharing the screen, or if there's
Yeah, I can stop sharing.
which is a great.
There we go. Okay.
Now we can see it.
Well, you know, in terms of people contacting me, this, you know, that's a little, you know, I can't give like medical advice to a specific person unless I've seen them. That's a little sticky kind of situation, you know. My email, I think, is on the UF website. It's pam.zeilman@neurology.ufl.edu. But, you know, mind you, if I haven't seen you personally, I can't give medical advice legally. Yeah.
Right. I guess a different question would be, since you are the top nurse practitioner programmer, is there perhaps a list of top programmers? Is there a ranking? Is there a way to find a list like that and then actually go to them? Could someone travel to Florida to make an appointment with you, or another practitioner nearby that they, you know, might want to try? Is that another thing? Do you recommend that if someone isn't necessarily getting the programming results from their person, can they get a second opinion or a third opinion, right?
Yeah, you can get second opinions. It really depends on where you're already at. I mean, if you're already at a large academic center, you're probably getting top of the heap care. It doesn't hurt to go somewhere else. You never know, right? If you're more in a smaller community and, you know, a provider that, you know, doesn't do programming all the time, maybe going to a larger academic center that has a busier DBS programming program, there may be someone there that can help you. I mean, we do have patients who come to our center who've been implanted at outside centers. For us to come here at UF, we do a 2-day evaluation. So the first day you see the movement disorder neurologist. and we have you get an MRI. You get the MRI either on the first day or the second day. And on the second day, you see that a DBS programming neurologist, or you see myself for threshold testing and programming. I would say in patients that have come from outside centers, sometimes they're fine. The only reason they come to us is they move to Florida, right? Sometimes they come to us because, we were able to find a setting that worked a little bit better. Sometimes our recommendation was to do another surgery, right? Sometimes it was just adjusting the medication. I can't tell you how many times we've gotten patients who are completely off medication because they want the device to do everything for them. And then it's us educating them. And, sometimes it's that their local provider told them too, but, they just, I don't know. So it was, just educating and readjusting medication. So, sometimes the answer isn't programming. Sometimes it's medicine. Sometimes programming is not going to be the answer, and it's maybe trying to stimulate in a different area of the brain. Okay. Not all centers will see patients that they did not implant themselves. So it's a matter of calling, centers and seeing if they're, number one, accept patients that they did not implant, and then number two, do they accept your insurance? Medtronic, I'm not sure about Abbott and Boston. I should know that, but Medtronic has a DBS provider website, so you can go in and you can enter your zip code, and it can look within a 25-mile radius, 50, 100, and 200-mile radius. And so then you can see, the areas of people who are registered on their site that do DBS. Now, that doesn't always mean that the person there does programming. So, for example, like our neurosurgeon does not do programming, but he's listed on that site. But if you called his office and you said, I want to, see someone for DBS programming, then they refer you to us, who we do programming. Those websites do not list nurse practitioners or physician assistants. They only list the physicians. And so there's some centers where the physicians don't do the programming at all. It's only the nurse practitioners or the physician assistants, but you're not going to find their name anywhere. You're just going to have to go through the gatekeeper of the center, and then they put you with whoever does the programming at that location. There's a lot of great people out there that do programming. So I would first try a larger center in your state, but you're always welcome to come to Florida if you want to come to Florida.
Excellent.
Which is great.
Yeah.
Folks, we are running quite a bit over, but that's okay.
That was great. We did.
This has been such an incredibly rich and valuable presentation. Please go back and watch it slowly, because a lot of the questions that are in the chat have been answered. And, the big summary here is there are over 1 million different programming options.
Wow.
It's kind of like stockbrokers, sometimes you get the really good ones, and sometimes people are good, and sometimes you get the ones that you want, So I think there are just a lot of different options for all of you. But it looks like the DBS is really helping in so many ways, and it's constantly advancing, and there are so many benefits to it, and a lot of people are benefiting all throughout. So one question was, though, going through TSA and metal detectors.
Oh yeah, I didn't have that in there. Yeah, you can. So the medical detectors that have like the arch, we don't want you to go through that. We'd rather you go around and have like the little wand thing. The one that's circular, you can do that one, no problem. But the problem is some of the TS, and especially when I recently traveled, I paid particular attention to this. Many of them, you have to go through the arch to go to the 360 thing. Only a few of them have it where you don't go through the arch. You can just go through the 360. So if you can ask to go around the back and enter that 360 around the back, and then you can do that one where you go like this and the thing goes around. But the arch, it can cause, depending on how high they have it set, it can cause like a surge in the battery and give the person uncomfortable sensation and deplete the battery strength a little quicker. And so that's why we say go with the wand. And all the companies give you little cards that say you have a medically implanted device and yada yada. Yeah.
Very cool. Somebody else just asked, where can we watch this video? You can check out our YouTube channel. If you missed in the beginning, we're PD Connect. We're a nonprofit in the San Francisco Bay Area. You can check us out at pd-connect.org. We teach exercise and education for people with Parkinson's. And this is our speaker series. Thank you so much, Pam, for being here. This was over the top, so great.
Yeah.
And we're happy you took us over. So thank you so much.
Thank you for inviting me. It was my pleasure to share my knowledge.
Incredible.
Very
Thank
incredible.
you so much.
Thank you so much.